Hey everybody, welcome back to Farmland, where we are here to serve up the freshest pharmacy information and insights to benefit advisors, employers, and anyone else looking for a better understanding of the industry. We take the biggest topics and dig deep, offering perspectives that you won't find anywhere else. And Farmland is brought to you by Farm to Table, an educational program from RX Benefits. And I'm here with my co-host, Tom Davies, Dr. Tom Davies, and we're going to be covering GLPs for diabetes, discussing all the positive benefits for those that truly need them in that disease state. Tom, good to see you.
I'm excited to be here, and I appreciate the audience tuning in. How are you, Langley?
I'm good. How are you? Thank you guys for having me back.
Awesome. So we have Langley Kyle again because we can't finish up our GLP segment without our GLP expert. So today we're going to have our question to think on. In a disease state like type 2 diabetes, where medication adherence is very challenging, should physicians follow the guidelines as they're written, or should they bend things to cater to patient medication requests? So let's throw that out there and start talking a little bit more about how these are used to treat diabetes.
I think that's a great question because we've seen the guideline change over the years, where for a very long time metformin was a standard. It's a great medication for lowering blood sugar without having the risk of having it drop out. And now we're starting to see, obviously, newer medications, GLP-1s, the ones we're talking about today, come out, and even here recently, new studies that really support the cardiovascular benefits of these particular drugs. And so you're starting to see the guidelines change. But, I think what you really have to look at is what that individual is experiencing. Are you looking to lower blood sugar only? Are you looking to lower blood sugar? Do you have a weight goal? Do you have, somebody who has multiple cardiovascular risk or a history of cardiovascular disease? And really kind of tailor those therapies, because GLP-1s that we're talking about today are great medications for those particular things. But, metformin is still a great medication if the goal is to, is only focused on the blood sugar at this point in time. So I really do think the guidelines are great, but you really do have to look at that individual and what they're experiencing, what other risk factors they may have.
So Tom, is drug therapy the only things that someone with a diagnosis of type 2 diabetes or even pre-diabetes, is that really the first thing they should worry about?
Well, with regards to, some of the steps that a member that's been recently diagnosed with diabetes or has been diagnosed with prediabetes, there's opportunities outside of medication therapy that can help to stem the potential development to type 2 diabetes or reverse the pre-diabetic state. And some of that is just secondary to diet and exercise, behavioral modifications, outside of the utilization of the drug therapies. And these treatment approaches are supported by the guidelines. What I've found interesting with regards to the guidelines is GLP-1s have been in the marketplace for coming up on, approximately 15 years or so? Maybe a little less, 12 years.
I believe the first one's going generic soon.
Yeah, so what I found most interesting is the change within the guidelines, secondary to some of the recent developments with regards to the more recently approved GLP-1s and the efficacy around those particular agents. So if we could take a step back and kind of get an idea of when did the research start with GLP-1s and how have we gotten here today? The impact of gut hormones with GLP-1 is a gut hormone on blood sugar stability, or homeostasis, we call it in the clinical world, started in the early 1900s. But it took until the 1980s for us to have the laboratory capabilities to isolate GLP-1s. And then it took an additional 25 years or so for us to have the first approved GLP-1 within the marketplace, which was Byetta or exenatide. There was not quite the uptake of exenatide when it was first released within the market, and some of the reasons for that, there was some administration difficulties associated with this particular medication. And then there were some warnings out of the trials that they observed within the animal studies that put patients potentially at risk for different types of cancer. So we just didn't see the uptake early in the 2000s that we have seen over the last 4 to 5 years or so.
think you've also seen, you talked about the administration. You went from that first drug being twice a day. Then we come out with Victoza that's once a day. Now we've got it weekly. You see that administration part change over time. And I think that also plays into some of that adherence. It's easier to take a medication weekly, especially when you're talking about injecting something versus an oral medication. I mean, most people would say, I would rather take an injection once a week instead of twice a day. So I think as we've seen those develop, it's become more appealing to patients to utilize those medications.
And I think just to parlay what you just mentioned, Langley, and what Tom just mentioned, you went from complex administration techniques. You don't really want to stick yourself with a needle twice a day. That's very off-putting from a patient administration standpoint. But now that we're at longer acting medications, we're also seeing the efficacy or the effectiveness clinically on A1C values improve over the years. I think back when exenatide or Beta came out, it was around 1% A1C lowering effect. Now all of a sudden you're starting to see it over 2.3% in things like Ozempic, with or without a combination of metformin as well. So the drugs are just getting better and better at treating particular conditions. And Tom, I'd like to get your opinion on this. Back in the early 1900s, insulin was the show. Now, you can lower your A1C 2 to 2.5% without going to insulin, and you're doing it once a week. How much of a satisfier and adherence is this? And from a patient outcome standpoint,
based on the dosing associated with the GLP-1s, which is generally standardized in nature. There is a titration phase, but once you get to a dose that you tolerate, it's pretty standard dosing. That's an advantage for GLP-1s. If we look at insulin therapies, oftentimes this is very personalized. That does take some more, and I hate to say it, but there's more onus on the patient utilizing insulin just to stay connected with their provider, of course, and make the necessary adjustments based on how they're responding to the therapy. In addition to the standardized dosing, the ease of use associated with the GLP-1s, once weekly dosing, like Langley mentioned, another important factor with regards to GLP-1s is oftentimes based on the data that's available, you may see similar reductions in A1C when compared to insulin. Insulin used to be the gold standard. When it comes to, if you want the biggest bang for your buck in reduction of A1C, it was utilization of insulin. Some of the new data that's coming out, there's information to support GLP-1s having a very similar effect. One of the risks with insulin is the potential for hypoglycemia, and this can be life-threatening in nature. When GLP-1s are used as monotherapy, which means all by themselves, there's a less of a risk of hypoglycemia associated with this medication. So there's really the not only the dosing, the ease of dosing, there also the reduction in the significant risk of hypoglycemia is an advantage for the GLP-1s.
And we recently spent 2 episodes with our esteemed guest, Langley Kyle, here about the potential off-label uses. But in certain individuals, a GLP-1 might be the gold standard for certain individuals. So, Langley, can you kind of address that? Which individuals should a GLP-1 be the most effective medication that you might want to deal with first line?
Yeah, I think absolutely. When you the off-label use that we see is for weight loss, but you do oftentimes see obesity and diabetes together. So I think definitely if you've got a type 2 diabetic patient who has a weight loss goal as well, but also if you see somebody who has a previous cardiovascular risk or current cardiovascular risk, a previous event, that could really benefit from that cardioprotective, results that we're seeing from the GLP-1, but also the renal protection as well. So I think in those subset of individuals that GLP-1s might be the one you want to go to first.
These members with diabetes oftentimes have comorbidities. And so ensuring that the treatment not only treats their type 2 diabetes, but also treats other conditions such as cardiovascular disease, kidney disease, for instance. I think there's real value associated with the guideline updates that support that information. And when we talk about the guideline updates, right, this is oftentimes we refer to the guideline updates here in the United States, the American Diabetes Association, and what are their thoughts on the utilization of these agents earlier rather than later. What's really interesting is internationally, if we look at the European Association, that's very reflective of what the ADA does here in the United States. The consensus opinion from both of these groups is to start these agents based on patient-specific disease. And it's likely led to the increase we're seeing with the utilization of GLP-1s potentially prior to metformin.
No. I think to follow through on that, though, yes, it should be patient specific when they're doing that. But that's also why, you do see that those the prior authorizations, for instance, like, well, do you want to slow it down? But yet that is how you determine whether or not it's patient specific and they are being utilized appropriately and not being utilized where, maybe metformin, because blood sugar lowering is the only goal, where that could still be first line versus those individuals who would be the best candidates for those.
And Tom and Langley, there are other medications that are in the diabetic realm, right? So you do have things like SGLT2s or sodium glucose co-transporter inhibitors, things like Farxiga, Invokana, Jardiance, things you see commercials about. Sometimes those might actually be a better first-line agent for cardiovascular or renal protection instead of GLPs when someone's not obese, right? So to back both of y'all up, it sounds like really, instead of a blanket approach, which is sometimes what it looks like we see in the market today, it's really about individualized patient care. Now, what happens to that doctor? Going back to our question to think on, that doctor that a patient goes straight to them and says, I want this medication, because they're looking at only the side effect of weight loss, right? So that's been the concern that we've talked about in the last two episodes. So if you were to tell a patient that has never been diagnosed, I think Tom hit the nail on the head. Let's start off with some lifestyle changes first. Let's look at what can be done first, and then let's go from there. And that's how you develop that start low, go slow approach that I'll teach us in pharmacy school about, and making sure that you're on the right journey and the right pathway versus trying to get to the finish line immediately. I think that's where the prior authorization helps, right, Langley?
Yeah, I think that's an excellent call out, because I think we see this over and over again, not just in this particular disease state, but we do look for how to get there quicker, how to get there easier, not to have as much impact on my day-to-day activity. But at the end of the day, being able to manage it through diet and exercise is going to be a more holistic approach. That's not to say that people don't progress and need those medications, because they are there for a reason. But I think we lose sight of that initial part. And that initial part, that diet and exercise, is what helps to maintain, when you do move to a medication, helps to maintain more consistency, lower dose. So I think that's an important part that we just, as a society, miss on that initial step.
I know we've talked about this a little bit earlier in a previous podcast, but I think it does warrant mentioning again. So, Tom, when we're talking about GLPs, even for those that need it in terms of the diabetic population, we don't necessarily know the long-term impact of these medications. So every medication has side effects, right? And we know that there's some pros and cons with medication use, regardless of what that medication is. So it comes down to just ensuring that we just don't know what we don't know yet from a large population base. So again, I'm sure you would advocate it's more about responsible medication utilization versus just blanket medication utilization. But can you add a little bit of color around just side effect profile of GLPs and how it compares to other medications that treat diabetes as well?
Sure. So we kind of went off, we did discuss a little bit on the risk of hypoglycemia. When GLP-1s are used as monotherapy, is not a significant risk for the patient utilizing the therapy. But some of the other common side effects associated with GLP-1s that are directly coming from the pivotal trials are GI related. So nausea, So nausea is a pretty common side effect associated with these medications. And depending on the drug, it can be anywhere from 20 to 25%. Diarrhea is another potential complication with the utilization of this medication. 15, 17% of the time, that is a complication associated with these types of medications. And then vomiting is another potential issue that was very commonly seen within the drug trials. Now, the way that you lessen these particular side effects is a slow titration. And then generally, in a majority of patients that are utilizing these therapies, these are transient in nature, which means they go away after a certain amount of time on the drug. What I think is potentially concerning is we don't know all the other potential side effects associated with these drugs, long-term use. So I know that there's been some concerns with regards to gastroparesis, small bowel obstruction associated with these medications. Is there truly a risk for pancreatitis, pancreatic cancer associated with these medications? So when it comes to the utilization of these medications, not only is it ensuring it's the right patient at the right time, but then having the ability to have ongoing monitoring associated with these medications, not only to assure that the benefit is noted, so you see reduction in A1C, you see a reduction in weight, but then you also have the ability to monitor for potential side effects that may not have been identified within the clinical trials.
I think, we talked about the drugs having been out for 15 years or so, but, we really saw an increase in the utilization. I mean, claims for these types of drugs went up 300% from 2020 to 2022. And while we've had them around for a while, they have not been used at the volume that they are today. And I think that we will start to see more and more things come down the pipeline, and you are hearing them talk about it, but just opening it up to that many people, we will start to see some of those potential long-term side effects.
300%. What an outstanding number.
Right.
I wish my wages went up 300% over the last 3 years.
Let's just hope groceries don't go up 300%.
Exactly.
Well, I think we're kind of at a potential break point because we've been talking about a pretty weighty measure, right? And so let's kind of break into our news of the weird. And news of the weird this week is actually going to be more characterized on drug development in general. We kind of hit on it a little bit earlier today. Tom mentioned drug development in general. So this goes back to the late 1970s, and it really focuses on this particular drug set, the GLPs. Whenever researchers were trying to isolate how does glucagon in particular influence blood sugar, one of the things they were looking at are these byproduct peptides or little proteins that help signal your body what to do in certain situations. And so they isolated and found GLP, or that is the peptide that causes this to happen in different ways, whether it's in your nervous system, whether it's in your gut, so on and so forth. But they had a hard time replicating it and sequencing it, doing the gene sequencing on it, which any type of drug development can lead to. It starts with gene sequencing and can lead to actual drug development and going out and going to market. So the interesting thing here is nature tends to provide a lot of answers to our questions. I think back to the opioids in general comes from poppy seeds, right? Opioid plants, and great pain control. Well, going back to nature on this one, what people might not realize is that first drug that was marketed, Beta, Tom mentioned it, called exenatide. It was actually developed after sequencing, get this, Gila monster spit glands. So who would have known that the GLP-1 craze of today was started off by the spit gland of a Gila monster? Tom?
Oh, this is extraordinarily timely news of the weird, because not only do we have nature impacting drug development, right? You said opioid plants. Foxglove is the origin of an old cardiovascular medication, digoxin or lanoxin. The timeliness of the Gila monster discussion is very well played, because we had notification nationally last week that we had our first death since 1930 associated with a Gila monster bite. And it was a collector in Colorado that was bitten by his quote unquote pet Gila Monster.
Well, I assume that I wonder what happened to that pet.
Yeah.
But yeah, that's very, I mean, it's definitely very timely, but nature provides all sorts of resources, which to me, goes from news of the weird to that's pretty cool. A lot of the stuff that we have today, it's not really new. It's just a reinvention of the old that people might have rediscovered over time. But now we're just smart enough to know exactly how to synthesize it over and over and over again. And so it's pretty cool for that. So speaking of how the past can influence the future, what do we see for the future of diabetes treatments? How have things really gone and moved toward from a pipeline standpoint, whether it's oral GLP-1s, the combination therapy? I think there's a 3-agent therapy that's coming, or a 3-mechanism therapy that's coming soon. What can you talk to us about that, Tom?
So there's a lot of study by manufacturers with regards to this particular class of medication, just based on its efficacy, and it's relatively manageable based on what we know today is the side effect profile. So as Bradley stated, there's some work being done on oral GLP-1s. We have one within the marketplace today. There is some additional onus on the member associated with how it has to be dosed, which may limit the uptake of this particular medication, but there's a lot of study currently being done on oral medications within this class that help to maybe reduce the onus on the member of taking 30 minutes before a meal or whatever the case may be. In addition to that, there's the multifaceted approach. So right now we have one of the newer products within the marketplace, Mounjaro, has a dual mechanism of action, GLP-1 and GIP. These are complementary in nature, but they're also looking to evaluate additional mechanisms of gut hormones they can target, triple therapy, quadruple set therapy associated with additive benefits if you were to target multiple gut hormones, which I think is a really interesting potential development within the pipeline. Right now, I think we have 9 or 10 different available products, GLP-1 within the GLP-1 or GIP class. There is at least as many within the pipeline are currently being studied. So a lot of development and attention is going into this particular class. Langley, anything you can add to that?
I think you covered what we have. I mean, it's interesting to see what we're doing in diabetes care. It is a disease state at least to date, we don't have a cure for. I know gene therapies have been thrown out there, and so that would be something interesting, although you go back to long-term, how that plays out. But I think it's definitely an interesting field to watch from just a pharmacist scientific standpoint. I think it's also interesting to watch as at the economic impact that it has on society as well.
So speaking of economic impact, you have this huge pipeline that's building up, right? And there's a reason why drug manufacturers are researching this. Is because there's a demand for it. People need it. At the same time, we've talked about other measures that people with type 2 diabetes can take. So so when you're factoring in the cost of these medications, what's coming to market, how much of impact it has on A1C and other measures, cardiovascular, renal, weight, all that stuff, when you start figuring that in addition to the side effects, this is not something that you can start, stop. This is something that's typically done from a maintenance standpoint, and with good adherence, good lifestyle changes, there are opportunities. I think, Tom, you mentioned it earlier, to de-escalate and potentially de-prescribe when you get to a quote, new steady state. So my question to the two of y'all is, what can plan sponsors, people that we talk to in the benefits world, what can they encourage their members, our patients, what can they encourage them to do to help them from a medication adherence standpoint, a lifestyle choice standpoint, to get them on the path to where they might not ever need these drugs after they get into a new steady state or a new homeostasis? I have not heard that word since pharmacy school, Tom, so thank you for bringing it back up.
It's my $10 word of the day.
I know. I'm going to give you 50 cents for that word too.
No, I think that's a great thing to bring up because, then you start into, it is a chronic disease and that requires management. And you can track how many times somebody fills a prescription, how many times they pick it up, but you can't know that based on that they're taking the medication when they're supposed to, how they're supposed to, that they are taking it versus just getting refills. And that's where I think where you see some of those disease state management programs where you have some accountability, some check-in, some education to reinforce everything else that we know is good and good to do for those individuals with those disease states.
What about food-based programs, Tom? Because we know that you are what you eat, and if you don't eat well, it can potentially lead to complications, weight gain as well as type 2 diabetes development, prediabetes and type 2 diabetes development. So is there anything out in the marketplace that can lead to a healthy eating type of process as well that plan sponsors might consider?
So as a patient, I just think it's all about not only just the necessary educational information, right? I need to know what I should be eating. I should have a meal plan, which there's vendors out there that work on particular meal plans and the benefits of these types of meal plans. But not only that, the ability to truly understand what is the benefit of exercise, and this one size fits all approach associated with just telling a member to exercise, maybe not something that may not hit home for the member. If you have a particular knee injury, you're likely not going to be very apt to run a half marathon, right? But just getting out and walking around the block is an opportunity. There's just really a personalized approach, not only to the diet and ensuring not only do they understand what drugs may benefit them, but then, not drugs, but what foods may benefit them, but also what do they have access to these medications? Or once again, medications, but do they have access to these foods as another important factor associated with, as we look at this as a holistic approach, is ensuring that we check those necessary boxes and not assuming that this solution will work for everyone.
And I think you accidentally hit on something very timely from that perspective, but it's all about access. Do you have access to, it's a holistic approach. Do you have access to information and education? Do you have access to accountability partners? Do you have access to the appropriate doctors? There are a lot of things associated with the forms of access. And just to kind of finish things up, access to food is one thing, access to accountability partners, exercise regimens, things of that nature. But we really didn't talk about access to these medications from the perspective of what's been happening lately. I think we might have mentioned it briefly in a podcast earlier, but just kind of tee up some segments that we're going to do and sprinkle in. A lot of the run on the market is these days for these medications lead to shortages for people that we're talking about today, GLP-1 utilizers that have type 2 diabetes. So how is the impact of recent shortages, at least for this particular medication, impacted overall population health?
And before we start down that path, I want to thank a listener to the podcast that actually posed this question to the team about the impact of shortages within the marketplace. And so we really appreciate the impact or the feedback from the team, from the listeners on this, for the team to ensure that we're tackling topics that are applicable to you and what you're seeing within the marketplace today. So I just wanted to offer a thanks to the feedback we received from our first couple of podcasts and tackling this shortage issue that's been in place, not only for GLP-1, but other medications within the marketplace over the last 5 years or so. So Langley, if you want to start with the impact we've seen when it comes to GLP-1s, and maybe we can touch up on some other impactful classes of medications that we're seeing within the marketplace and how those shortages are impacting patients, patient families, and then potential opportunities to solve for those shortages as they exist today.
Yeah, absolutely. I mean, it's a great question and a great point because, as we mentioned earlier, this class of drugs we saw increase 300%. And you saw, all the social media, and I know we kind of discussed this on earlier podcast because, you had it all over for weight loss, and you saw people using diabetic medications for the weight loss. And so you really had a very large demand for this class of medications, and the supply wasn't meeting up with that. And as a result, there were access issues for patients who do have diabetes and depended on this particular medication to sustain their blood sugar. And that's really where you start seeing tightening it down, making sure that they are being used for those, FDA approved indications so that they could have that access. But you also saw other entities introducing compounds because it wasn't, it wasn't something that was readily available. And so you did see some compounding coming out of it. And I think, awareness of patients, knowing what they're getting, where they're getting medications from, using the advice of their, local pharmacist, talking to their physician about it to make sure that, they do have access to the medication. And in some instances, there may be, we did talk about when to use certain diabetes medications, working with your prescriber to get a therapy. If you're not able to get the one that you have been taking, what could you do in the meantime to bridge that gap? Because I think we've started to see like that was unique, but we are starting to see more and more drug classes have shortage issues.
And Tom, that was just based on an overwhelming demand with inadequate supply. That the inadequate supply was due to the tsunami of demand. But in some cases, it's not always about that type of supply crunch, right? There are other medications out there that can experience different types of supply crunches, right?
Right. So tidal wave of when it comes to GLP-1s, tidal wave of interest has impacted the supply. It has been to a degree multifactorial when it came to where we started with some of what triggered the shortages. Demands is key, but then also the manufacturers of one agent in particular, Ozempic, had some difficulty with their administration device, which led to some shortages, I believe in 2022 or so. But we saw when that drug went on shortage, there was switching to drugs within the class. So you started to impact the supply of other drugs. And it's this circular kind of event that's going on within the marketplace today. Demand, manufacturing difficulties associated with these medications. There has been some recent changes with regards to limiting 90-day supplies to limit stockpiling of medications to ensure that the patients that need these drugs have access to them and are not having to jump through hoops on a monthly basis to ensure that they have medication available to them. So GLP-1 is a perfect example. But there's been others that have impacted the marketplace. In fact, I read an article yesterday that we haven't seen this many shortages in the marketplace. I believe there's 310 different medications that are currently on shortage with the marketplace for over 10 years now. And one of the shortages that's been extraordinarily impactful to the general population, so patients that aren't hospitalized, for instance, is the shortage of stimulant medications for the treatment of ADHD. So we are still wrestling with the shortages that exist within the marketplace. And there's a lot of finger pointing that's going on between the DEA that has set allotments for manufacturers to make medications and the manufacturers not being able to meet the demand associated with the shortage that exists today. So stimulants is still really a hot topic item for not only people that we work with, right? Our clients, our members, but then on a personal level, I'm hearing about this at least a couple times a month at soccer games and basketball games or picnics where members don't have access to the medications and they're having to do this runaround and phone pharmacies and trying to locate medication and oftentimes rationing medications or going without medication. That is not clinically what we want these members and patients to do.
Yeah, I think I read one where it said about 49% of patients report that they've had delays or stopped taking their medications. 24% report rationing, taking it every other day, taking a half to make it last longer. And absolutely, that's not ideal for managing a chronic disease state when you don't have that consistency.
And then you throw in affordability because when you have shortages of things that are relatively cheaper generics, right, that are on lower tiers for people that are either in a copay situation or a high deductible health plan situation, a little bit cheaper. When those generics have issues of getting procured, and we can talk about why you have to call different pharmacies and how certain regions of the country may have different issues than others. But ultimately, it's caused pharmacy benefit managers to open up their formularies, and things that were previously excluded, the brands, are now being included. And so ultimately, these shortages can drive up costs for not only the plan sponsors, as they pay for these brand names that might not otherwise be rebatable because it's an excluded medication, right? But now all of a sudden you have patients that are now paying a tier 3 copay if you're a flat copayer, or you're paying a much higher amount. So it's a catch-22. And as Tom mentioned with GLPs, it happens in other segments like ADHD medications. You can't get Vyvanse, let's go over to Adderall XR. Can't get either one, let's go over to Concerta. And so it's a constant flipping and back and forth. And while these are the same class of medications, they are different chemical entities. So we don't know what the impact of the constant changing back and forth will do on anybody, just as much as we don't know what that would do for GLPs or other things. But I do want to point out something, Tom, you mentioned, just to kind of rehash it again. You mentioned about hospitalized patients and where the biggest shortages are today. Langley, Tom, and myself, we don't necessarily see it in the pharmacy benefits world from an outpatient drugstore payment basis. This is happening in the hospitals where you can't get certain things like epinephrine, lidocaine for surgeries, and so on and so forth. Those are things that have been going on for multiple years. And there are some entities out there that are actually looking at how do I start manufacturing more of that here? And there's regulatory obstacles and things of that nature that are trying to help alleviate that little bit of a backup there. But any more that you can add on that, Tom?
I think that one of those call-outs, epinephrine, right? You brought up in hospitalized patients. One of the hot topics right now is the lack of stock of particular chemotherapy agents, and how there's been a transition away from manufacturing these agents because there's not a lot of profit that can be made currently today. And oftentimes when it comes to the quality that the FDA uses, their quality measures that the FDA utilizes to ensure that these products can be used and are available, it's really kind of black and white. So these organizations that potentially want to do more to ensure quality is ultimately going to cost them more, but you've already got agents with extraordinarily slim profit margins associated with them. So as a manufacturer, those are not the opportunities that I'm going to spend a lot of time on because it's ultimately going to be detrimental to my business model. So I think there's got to be continued conversations with the FDA on, you know what, if we're going to take extra measures to ensure the quality of our products and ensure the supply of our products and build in redundancies, because all of those things cost money, we have to be rewarded for those efforts.
And just think, that entire discussion came from one viewer question. So again, to echo Tom, thank you for asking these questions. These are the types of things that really get us going in the morning to be able to consult and help you navigate this landscape. And we're getting at the end of our time now. And so I want to make sure that we thank our audience again. The next podcast that we do, we're going to actually tackle the topic of prior authorization. Are they good or are they evil? It's something that's been in the news today, so we're going to be tackling that next time. But until that, Langley, thank you much. We appreciate you coming on again. And Tom, always a pleasure, my friend. And for Farmland, I'm Bradley Nelson, and I guess we're out.
Until next time, guys.